Uh, Very good afternoon, and thank you for this opportunity. Dr. Chandana, you have already made it very clear where calcium score is required. I'll go ahead and talk about diabetes in heart failure patients. How to identify those which we are missing, or when a patient comes to us. We know it is an independent risk factor, and more men and women are suffering from diabetes, and they are more and more prone to have heart failure, which is now rampant as preserved heart failure, or a patient which has got an ejection fraction which is almost more than 50%, but they develop diastolic dysfunction, and that is the early indicator. Now, diastolic dysfunction was one thing which we have been seeing very regularly in our echocardiography reports which are coming to us. But the only problem is that we were not being able to identify a few years back that what was happening. But now we come to know that this is heart failure with preserved ejection fraction, and that is one indicator. We'll go more beyond and find out like how we can actually prevent these patients, and how we can find out that these patients are actually going into heart failure. Early asymptomatic cardiac dysfunction can be experienced with notable symptoms of heart failure, which changes in the structure and function. That is mainly because of dyslipidemia, endothelial dysfunction, cardiac myocyte hypertrophy, the RAS activation, the calcium handling, autonomic dysfunction. So this is all because of insulin resistance that is coming on to the cells. And ultimately, diabetes, which is more and more at risk of developing heart failure or heart disease. It's a vicious cycle. We have diabetes, we leads to heart failure, and heart failure can lead again to diabetes, and more and more blood sugars keep on increasing, and more blood sugars keep on changing. So when we look to the poor glycemic control, with every 1% HbA1c rise, the incidence to heart failure increases by about 8 to 36%, which is quite significant. Very recently, there was one patient, one doctor's father. He came to me with just breathlessness and strength and chest pain, and his echo was showing diastolic dysfunction, and his gradients were very high. Started the patient on treatment, and immediately he settled down, though his angiography was normal. So these are the things which are to be identified previously before the patient starts experiencing these symptoms. Changes can be identified by structural changes, can be identified either by an echocardiography or ECG also. Now, impact of diabetes: 7% increase in the risk of cardiovascular death and 27% increase in the risk of heart failure hospitalization. Hospitalization in heart failure causing remodeling of the heart. Prevention is more important in these type of patients. Now, the challenges are, until recently, type 2 diabetes and heart failure had been managed independently, but now diabetic cardiology comes into force. Effective treatment is the need of the hour. Heart failure therapy that is protective against the incident of diabetes and worsening glycemic control are to be taken. The factors which are responsible are poor glycemic control, uncontrolled blood sugar levels, hypertension, high blood pressure causing fatigue and stress to the heart muscles, contributing to the subclinical dysfunction, family history, genetic predisposition, advanced age, and older diabetic patients which are more likely to exhibit subclinical cardiac abnormalities. Now, how do we identify these type of patients of subclinical? I'm talking about subclinical heart failure, not those who are coming with full-blown heart failure to our OPDs. Cardiac evaluation, routine echocardiograms are early signs of cardiac dysfunction. Biomarkers like NT-proBNP, BNP can be indicated, and ECG, which is not as sensitive as imaging, but it reveals subtle changes. Echo, like a subclinical left ventricular hypertrophy, has and the tissue Doppler and strain patterns in a diabetic in the absence of coronary artery disease with LV dysfunction, LV hypertrophy. There is a QRS duration which is increased in an ECG. Higher left ventricular mass and higher left ventricular thickness is associated with the development of cardiovascular disease in type 2 diabetes. This was a study done by Amre, where they have seen the changes which has happened in the ECG. What is the effect of diabetes on the biomarkers on the ECG? There are specific changes which happens when we look over here onto the cardiac myocyte, and the ECG changes and the T changes, and these are the things which can be picked up early when the patient comes. QRS duration has a positive association with cardiovascular outcome in diabetes. LV mass, LV mass index, and the wall thickness is a positive association with cardiovascular outcomes in cohorts with type 2 diabetes. And type 2 diabetes is an independent associated with reduced stroke volume and increased LV wall thickness. Now, the T wave amplitude, if you can just look, this is the matched control T wave in type 2 diabetes, which is of a short duration, and we have type 2 diabetes with a long duration. There is a decrease in the R wave, there is decrease in the T wave, and further decreases as the diabetes progresses, especially in leads 3 and AVL. These are the subjected which we can see. And when we compare it over here, you can see the blacks are the actual control and the red is this is how the ECG pattern. So what we have a patient who has got an echocardiographic diagnosis of LVH, but the ECG is not showing left ventricular hypertrophy. So that is because there is a suppression of the Lenoid calculation. The 25 square root is not there, and the progression, there is a poor progression of R waves which actually happens. So that is the first indicator. Another thing is that these patients have got resting tachycardia. That means the patient is suffering from cardiac autonomic neuropathy. So that means the heart and the cardiac myocytes are already getting affected because of more and more endothelial dysfunction. Now, I'll be just going through in brief about 3 cases and discuss a few drugs. This is a lady, Sarita, 68-year-old, diabetic hypertensive dyslipidemia, EGFR of 55. Now, over here, the EGFR is coming down. Creatinine is 1.5. Next is a 70-year-old person. He actually has got heart failure reduced with a creatinine of 1 and EGFR of 77. And we have got Siddhant. He is a 59-year-old with preserved ejection fraction, EGFR of 77. Now, according to the guidelines, European Society and ADA guidelines, metformin may be the safe for these type of patients in heart failure, and ADA also recommends SGLT2 and GLP-1 for reducing the cardiovascular events and heart failure. When we look to the prospective studies which has been done with metformin, it is turned out that metformin is one of the very safe drugs which actually helps in cardiovascular remodeling. When we come to EMPA-REG trial and when we come to the CANVAS trial, 14% risk reduction and 35% of hospitalization is reduced. So SGLT2 inhibitors are playing a very, very important role in heart failure and diabetic patient. Yes, a very recent study has been done where we are seeing lots and lots of symptoms of UTI, genital tract infections coming in. It is more with cardiovascular disorders. So here we need to be careful when we are administering drug, but this is a very, very important drug which has come out. Then when we come to GLP-1 agonists like the liraglutide, the semaglutide, the exenatide, yes, there is a median follow-up, but there is no difference in the risk or heart failure risk reduction which has been observed. When we come to the SGLT2 inhibitors, yes, all these trials, the CANVAS, Credence, DAPA, Declar-TIMI, the EMPA, Emperor, all these trials, they show at least 14% risk reduction in these type of patients, which is very, very important. With SGLT2, 31% reduction in hospitalization has been seen, and the cardiovascular mortality is 13% risk reduction with GLP-1 agonist has been seen by the LEADER and HARMONY trials. Similarly, 10% risk reduction, but the more is seen with patients who are on either dapagliflozin or empagliflozin. When we look to the clinical outcomes of glycemic medication, we see that SGLT2 are more favored to decrease the risk of cardiovascular mortality and heart failure hospitalization in our diabetic cardiac patients. So if I summarize all the 3 cases, metformin will be the drug of choice with SGLT2 receptors for the first patient with the decreasing GFR. Metformin and SGLT2 may decrease the hospitalization risk for a patient who has got reduced ejection fraction. Metformin and heart failure reduction with the empagliflozin is a patient for heart failure with preserved ejection fraction. Thiazolidines have to be avoided. And yes, in DPP-4 inhibitors, sitagliptin is only one where the TCOS trial has said that it is non-inferior. So the management, optimized control, blood pressure control, lipid management, lifestyle, cardiac medication like ARBs, SGLT2 be considered. In nutshell, type 2 diabetes and heart failure pathophysiology is very, very complex. Significant cardiovascular outcome is there. Anti-hyperglycemic agents reducing heart failure mortality and morbidity is very, very important. SGLT2 and GLP-1 are one of the newer drugs and a new hope for diabetic patients apart from ARNI and the MRAs which we are using for patients of heart failure. Thank you all, and this is all, madam.